So we're going to show you ankle range of motion. So an ankle joint is a hinge joint that moves up and down for the most part. Very minimal motion in rotation. So for the most part, an ankle joint is a hinge joint that moves up and down. It requires a certain degree of motion with pending the ankle if it's bent or if it's straight. In this situation, we have the knee straight, and we're going to see how much motion at the ankle joint. So we're going to look at the outside of this bone area. We call it the lateral column, and according to the Achilles as well as this fibula. So we're going to look at that. As I'm doing this, with just doing that, we can see clearly if this was 90, this is at least 20 plus degrees without using a tractogram. So that's phenomenal. So that was an Achilles lengthening, which is stab, stab, stab. They call it a hook procedure, H-O-K-E, Hook's procedure. And that is required when you do flat foot reconstruction to relieve the pull and weakens the grade, one whole grade of the Achilles attachment, to allow back the elevation of the front of the calcaneus, which is the heel bone, and so therefore the talus, which is a bone in the front of the ankle, can have that sustentaculum tali alignment. We call it the cyma line as well, the metatarsal joint. Nonetheless, which is this section. So this is what we did the first thing. Now we're obviously looking at a scar. This was a little tiny cut. We had to put a bone graft into here and a small 2-hole plate, which is a neutralizer plate. Sometimes I put compression plates as well. There is tons of compression when you put the bone graft in. Usually I go between 1 centimeter to 0.9 centimeter, which is 9 millimeters, depending on what the correction is. What we're trying to do is put a graft here to allow transverse plane motion, so the motion going that way, because when he stands, before he would go out, his toes would stick out. So what we're trying to do is bring the toes back in and aligning the second toe to the shin bone, aligning the second toe to the kneecap. And so that's what I do. And depending on that, I decide what size graft, but typically between 9 millimeters to 10 millimeters, which is about a centimeter, and usually go about 1.5 centimeter away from the calcaneocubo joint. And it's a little tiny incision. Sometimes you have to reflect the tendons. Sometimes you have to reflect the intrinsic musculature in there. The extensor digitorum brevis. Most of the time you don't have to do much except just cut straight down and relieve some of the periosteal layers and cut the bone and put the graft. Some people break the bone straight and through, others don't. What you need to do is create a wedge. That's the bottom line. So now we're looking at it from this angle. So I'm going to take the phone from my assistant and I'm going to point it towards this side. So if I'm pointing towards the bottom, so I'm looking at the foot in regards to the leg, second toe to leg, and now I'm looking at this little tiny thing. On this side, what I like to do is called a modified Kidner procedure. I'm sorry, let's make it wider, less wide. So that's the heel bone, that's the ankle bone, that's right in the front. And so what we shave the bone is, and then what in his situation, he had a fusion before on top, as you guys can see that was a beam, a big heavy beam fell down that required fusion. So some podiatrists, orthopedics, as well as different providers do flat foot reconstruction with a medial column fusion and teno suspensions and what have you. I'm not a big fan, and obviously you can tell why we had to do the whole reconstruction. So therefore, meaning transverse plane versus rotation, which is called the frontal plane, and sagittal, which is the Achilles lengthening. So in this situation, I did a little incision here and transposed the tendon on the bottom further up with little 2 tiny anchors. Now, I don't use Mitec, which is metallic. I use absorbable anchors, and those little anchors dissolve over a period of time, and they work phenomenal. You can see from this side, you can see the arch as I pull upwards, and still there's an arch, and so that's very good. in regards to emulating weight-bearing surface. And as I push downwards, you can see the arch further. The bottom line is Achilles lengthening is a must. You need to decide if it's Achilles versus gastric recession versus a block of bone in the front that's not allowing motion at the ankle joint. A little tiny incision on the inside called a modified Kidner works phenomenal. And then what I do, then jump to the other side and work on the other side. So I usually go this side, that side, which makes sense because if you're going to do this, the outer side, the whole thing is going to move in. And it's going to be fairly difficult to work underneath this area. So I usually clean it up, bring the tendon and transpose it where it needs to be, knowing the fact in the position that I would like it, and then I go to the other side and we did the other side. So on an x-ray, when we look at it, it looks like this. So that's the bone graft with the screws. Sometimes what I'd like to do is go eccentrically at the proximal screw to create compression. So when I go in an angle to create like a staple phenomenon, but the bone is so tight, compressing the bone, sometimes that could work against you and crush the bone, and then you have no correction at all. So just keep that in mind. You would know that intraoperatively, knowing how much compression there is. The ball is in the socket, everything is aligned where it should be. Now showing you guys where the fusion site from before. This is what was fused before because of the beam that fell on his foot. So the side profile will look like this. So the tibia and the fibula are aligned. There is no more rotation of the talus, which is this bone. There's no more rotation. There is no break in the cyma line. The opening of the sinus tarsi is nice. There's no obliteration. This triangle moves forward. It's a whole cascade of things because of pronation, hyperpronation, and arch depreciation. The arches are up, as you can see, a nice arch, no sag. This is called Meary's angle, M-E-A-R-Y, Meary's angle. When it shoots smack in the middle, it should shoot out to the big toe, and so that's exactly what we achieved. So overall, very nice correction, and that's flat foot reconstruction, at least in my book. But again, do understand there are planal dominances, there are major players and minor players. Address the major two players, and the minor player automatically can realign itself. Overall, this is one way. Sometimes what I do is a derotation as well, break the heel to correct that rotation called a varus. To achieve a varus from a valgus. So anyway, this is what it was, and hopefully you guys saw it. He's about now 3 months out, a little shy from 3 months, no swelling whatsoever. He's wearing these kind of boots, which is a Nike type of boot, which is phenomenal. He has inserts in his shoes from before, so he should be fine. He's in physical therapy and he's doing phenomenal. Thank you.